Hello everyone and welcome to the viewing and listening audience to this, the 18th meeting of the Joint Select Committee on Social Services and Public Administration. This is the committee's first hearing with stakeholders pursuant to its inquiry into Trinidad and Tobago's response to the prevalence of non-communicable diseases with specific focus on diabetes, cardiological disease, and cancer. Members of the general public are invited to submit their comments and questions via the Parliament's social media platforms, YouTube channel ParlView, or via its Facebook and Twitter accounts. At this time, I'd like to allow members of the committee to introduce themselves, starting with Member Mohit.
Thank you very much, Chairman. Good morning to you, Chairman, members of the committee, as well as those joining us from the Ministry of Health. Vandana Mohit, member of this committee.
Member Monroe.
Thank you very much, Chairman. Good morning to you and members of the committee. Good morning to members of the Ministry of Health team. Welcome. Member of the committee, Roger Monroe.
Member Naked.
Good morning, everyone. Looking forward to questioning all of you.
Thank you all. I am the committee's chairman, Paul Richards. We also have members Esmond Ford, MP, Penelope Beckles, MP, Andrew Hansen, MP, and Abhinav Singh, MP, who are members of the committee but are not able to be with us today due to conflicting schedules. Thank you all for being with us today. The inquiry objectives are as follows. There are three main objectives in this inquiry. One, to examine the efforts of the state to counteract the effects of specific non-communicable diseases within the population. These, as I said before, diabetes, heart disease, and cancer. Two, to examine the efforts of civil society to counteract the effects of these non-communicable diseases, including diabetes, heart disease, and cancer. And three, to determine the main policy changes, actions, and interventions that may be necessary to effectively respond to the increase in non-communicable diseases in Trinidad and Tobago. At this time, I'd like to allow members of the stakeholder groups to please introduce themselves. Go ahead, please.
Thank you, Chair. Good morning, everyone. Asif Ali, Permanent Secretary of the Ministry of Health.
Good morning, Chair and members. Dr. Roshan Parasram, Chief Medical Officer, Trinidad and Tobago.
Good morning, Chair and members. Dr. Maria Clapperton, Director of Non-Communicable Diseases, Ministry of Health.
Good morning, Chair and listening audience. Dr. Adish Serju Singh, Director, Women's Health, Ministry of Health.
Good morning, Chair and members. Tricia Cummings, CARICOM Focal Point for Cardiac Management.
Good morning, Chair and members. Angelina Ramprasad Pierre, Acting Chief Executive Officer at the Eastern RHA.
Good morning, Chair and members. Davlin Thomas, CEO, North Central Regional Health Authority.
Good morning, Chair and members. Dr. Brian Amo, Chief Executive Officer, Southwest Regional Health Authority.
Good morning, Chair and members. Anthony Blake, CEO, Northwest Regional Health Authority.
Good morning, Chair and members. Dr. Kelly Elaine Mike, Medical Director, St. James Medical Complex.
Thank you all for being here. Just before I allow the Permanent Secretary, Mr. Ali, to deliver opening remarks, I just want to lay some context, take some time to lay some context to the importance of this kind of inquiry based on the statistics and data that we've been able to, the Secretariat has been able to gather regarding non-communicable diseases, not only in Trinidad and Tobago and the Caribbean, but around the world and its impact on people's health around the world. Non-communicable diseases refers to a group of conditions that are not mainly caused by an acute infection and generally results in long-term health consequences that require long-term treatment and care. In this inquiry, we'll be focusing on diabetes, cardiovascular disease, and cancer. Here are some key facts about NCDs, as reported by PAHO. Non-communicable diseases, NCDs, kills 41 million people each year worldwide. 71% of all deaths globally. In the region of the Americas, 55 million deaths are attributable to NCDs. Each year, 15 million people, 2.2 million in the region of the Americas, die from NCDs between the ages of 30 and 69. Over 85% of these are considered premature deaths, which occur in low and middle income countries. Cardiovascular disease amounts for the most NCDs, 17.9 million people annually, followed by cancers, 9.0 million, respiratory diseases, 3.9 million, and diabetes, 1.6 million globally. These four groups of diseases account for over 80% of all NCD deaths. Tobacco use, physical inactivity, harmful use of alcohol, and unhealthy diets all increase your risks of dying from an NCD. In terms of Trinidad and Tobago, recent data has indicated 14.8% of the country's adult population is living with diabetes. And diabetes continues to generate a substantial burden on overall disease in the population. The increase of this non-communicable disease has placed an added strain on the country's healthcare system, as you all will realize because of your positions. In terms of the global outlook, the leading non-communicable disease throughout the world in the last 2 decades, 20 years, has been cardiovascular disease. In 2008, there were 17 million deaths due to CVD, 48% of NCD deaths, and over 80% of cardiovascular deaths. In terms of the prevalence of cardiovascular disease in Trinidad and Tobago, cardiovascular disease is the #1 cause of death in Trinidad and Tobago. Physical inactivity and unhealthy diets, obesity are fueling what is described as a crisis of NCDs, including heart disease, stroke, diabetes, and TNT, with heart disease as the leading cause of death. ParlView says TNT is one of the countries in the region with the most cases of arterial hypertension. It is reported that while the Caribbean has the highest rates of hypertension, accounting for a quarter of the population, Trinidad and Tobago has an even higher hypertension number than the overall region. It is reported the Caribbean has a 23% rate of hypertension compared to 17.6% overall, while Trinidad and Tobago, that number is 25.8%. That follows from 29% in men and 23.7% in women. In terms of cancer, according to World Cancer Research Fund International, there were approximately 18.1 million cancer cases globally in 2020. Globally, breast cancer and lung cancers were the most common cancers worldwide, contributing to 15.5% and 12.2% of the total number of new cases diagnosed in 2020. Colorectal cancer was the third most common with 1.9 million new cases in 2020, contributing to 10.7% of cases. And I think I will just end with a Caribbean perspective. CARFA report, breast cancer is the main cause of cancer deaths among Caribbean females, accounting for 14 to 30% all deaths attributable to cancer. So those statistics kind of paint, well, not the kind, they do paint a startling reality that we must face in this country, and hence this committee has agreed to look at the efforts of the state in counteracting the effects of specific non-communicable diseases. We're focusing, as I said before, on diabetes, heart disease, and cancer, and what's working, what's not working, and hopefully we'll come up with some recommendations to impact policy and operational issues to stymie this trend, which is not going in the right direction. At this point, I'd like to invite the Permanent Secretary in the Ministry of Health, Mr. Asif Ali, to deliver opening remarks.
Thank you, Chairman. Good morning again, Chair, members of the committee, CEOs of the RHAs, my colleagues of the Ministry of Health, and the viewing and listening public. At the risk of maybe repeating some of what you said, Mr. Chairman.
Please repeat. People need to hear it.
So NCDs, non-communicable diseases, as you said, they are a group of non-infectious diseases. They are not transmitted from person to person. You already mentioned the major NCDs, cardiovascular, heart attack, strokes, diabetes, chronic lung conditions, cancer. I need to emphasize that premature death from NCDs is largely preventable. I think that's an important point to make. You mentioned some of the risk factors that lead to NCDs, and a lot of those risk factors are within our control on an individual basis. You mentioned the food that we eat, amount of physical activity that we engage in, and other factors such as alcohol consumption and smoking. At this point, I want to reaffirm the commitment of the Ministry of Health and the RHAs towards the provision of quality health care through initiatives geared specifically towards strengthening of primary health care, which by extension looks at the prevention and the management and control of NCDs. At the ministry, what we're doing right now is using a life course approach in addressing the issue of NCDs. This holistic strategy focuses on promoting intergenerational health, wellness, and well-being throughout the various stages of an individual's life, starting from birth and infancy, straight through to adolescence, adulthood, and then the elderly. At the ministry, we encourage everyone to join us as we work together to reduce the prevalence of NCDs nationally. While the ministry continues to strengthen existing resources, we also encourage the nation and the population to join with us in making informed, healthy lifestyle choices. And this goes beyond simply treatment of NCDs as we seek to implement sustainable measures that would help to prevent and detect the early onset of NCDs, thereby maintaining the health of our population. In this regard, Mr. Chairman and members, we hope that today's proceedings will allow the population to be better informed about NCDs and by extension, contribute towards the prevention, management, and control of these diseases. I thank you.
Thank you, Mr. Ali. The first question is based on one of the data points that I called out earlier on. PAHO says that Trinidad and Tobago is one of the countries in the region with the most cases of arterial hypertension. It reported the Caribbean has the highest rates of hypertension, accounting for a quarter of the population. But Trinidad and Tobago has an even higher hypertension number than the overall region. It reported that while the Caribbean has a 23% of rate of hypertension compared to 17.6%, that's just over 6% difference, while TNT has a 25.8% overall rating, 29% in men and 23.7% in women. Why is Trinidad and Tobago's numbers trending in that direction? Are there particular reasons that you can share with us? I know lifestyle choices, etc., but Trinidad and Tobago, from my quick cursory look, probably invests more in medical health care than most of the Caribbean countries. But our numbers are much higher, suggesting there's some gap in attaining the objectives. Why? What are the main reasons contributing to our overall rate being 25.8 compared to a 23% rate for hypertension in the Caribbean?
Sure. Thank you, Chair. So I'll let Dr. Clapperton answer that, but just to make the point that you did mention spend in terms of in the health system, and I did mention the point about treatment. So a lot of that spend currently is in terms of treatment, but at the ministry we're trying to focus more on prevention, as I said. So you start to see a shift in that expenditure, hopefully, towards prevention, because once you prevent and you reduce the severity and the incidence of those diseases, treatment should correspondingly start to decrease. But I'll let Dr. Clapperton, sorry, CMO will maybe jump in first. Thanks.
Yeah, just to start a little bit, and then I'll hand over to Dr. Clapperton. So every population in the Caribbean and the world is different in terms of the way it is made up, based on genetics, based on the food that we eat, based on our lifestyle. Cultures are different. So to compare one country to the next is oftentimes a little bit difficult when you look at it from a statistical perspective. Having said that, our country has over the many decades shown that hypertension, which is more prominent in the Afro-Trinidadian, Afro-Caribbean population, as we all know, tends to be higher than our Caribbean brothers and sisters. And contributing towards it, in my view, after looking at the data, seems to be lifestyle more than anything else. Hence the reason we're trying to create a paradigm shift where we shift away from the disease model, where we're treating the end result of hypertension. So we're treating the end result at this point, which is cardiovascular disease, strokes, and the lot of it. And we're trying to shift away and reinvigorate primary care on a whole. So the focus in the Ministry of Health is now towards a wellness model, and we really want to get that across to the public. To do that, we need the cooperation of whole of government and whole of society. It is not a one ministry thing. It has to be all ministries. It has Ministry of Agriculture, Ministry of National Security, for example, to create safe spaces for us, a Ministry of Sport, and many other ministries, Ministry of Education, because our children are what I think will drive change in the future. This is not going to happen in 1 year or 2 years. It's something that we will see over generations. But Dr. Clapperton can go
just before you go to Dr. Clapperton,
sure.
Dr. Passer, part of the objective of our committee is for the public to really get the message.
Right.
And very often we use terms lifestyle choices.
Yeah.
That we need to break down, because I really want the public to understand what we're talking about here, so that they can start to assimilate and process it.
And we're talking about risk factors for these diseases, hypertension, diabetes, heart disease, and the ones that we can do something about, which we call modifiable risk factors. So diet, what you eat; lifestyle, we talk about lifestyle choices. Lifestyle choices include diet, but it has a lot to do with exercise, as well as, of course, stress levels as well could be considered a great factor in some instances, the type of job that you do. So our focus was really on the modifiable risk factors. It includes tobacco use, it includes alcohol consumption as the main ones. When you talk about food, we're looking at fat consumption as well, triglycerides and certain types of fats. And our center is really to go at each one. So we go at increasing exercise, we go at increasing water intake, increasing fruit and vegetable intake, decreasing tobacco use, if we can get rid of it altogether in terms of use, decreasing alcohol consumption. So those are the 5 big ones, I think, that we want the public to partner with us and all of government and society to get on board.
I would ban tobacco, but I'll have fire and brimstone come down in my head.
So we go towards, and that's where the TT Moves banner kicks in, and you will hear from Dr. Clapton and others as to how we have tried to create this sort of culture of behavior change, and we have brought on to the ministry a doctor who is assigned to UE, works with UE as a head of department in that field, behavior science, but she's actually vetting our communication strategies. So we bring the behavior change component to all our corporate communication messages as they go out as well.
Dr. Clapton.
Thank you, Chair, and thank you, Dr. Parashram. To answer your question, Chair, just to add some more of a clinical perspective as to the nature of the illness that is hypertension. Hypertension or high blood pressure, which is known more commonly as high blood pressure, is an illness that we can categorize as 2 forms. So there's primary hypertension and secondary hypertension. So in primary hypertension, 90% of the cases are due to primary hypertension or essential hypertension where there's no known cause, right? The other 10% are persons who would have secondary hypertension where there may be underlying medical conditions that would have contributed to them being predisposed to having an elevated blood pressure. That, once identified, can be managed and treated. But 90% of cases are persons who suffer from essential or primary hypertension where there's no known identifiable cause. Specifically to our population, if we look at risk factors that contribute to persons who have essential hypertension, you have what we call modifiable risk factors and then non-modifiable risk factors. So they're the things that we can change and they're the things that we can't do much about. The non-modifiable risk factors would be things like ethnicity and genetics, as Dr. Parashram would have alluded to. And if you look at our makeup of our population, persons in the Afro population are at greater risk for hypertension. So looking at the makeup of our population, we are already predisposed to and having these risk factors inherent that are non-modifiable. But what we can do something about would be the modifiable risk factors. So looking at our intake of salt in our dietary consumption, looking at our levels of physical activity, we can aim to increase levels of physical activity and reducing consumption of alcohol and use of tobacco. So we at the Ministry of Health, given the nature of the illness that is hypertension, we focus on modifiable risk factors and mitigating and reducing risk factors for hypertension in that way. So this is why a lot of the measures implemented would speak to encouraging members of the population to maintain their health and adopt a wellness approach towards health maintenance. And that is what the TT Moves banner would speak to, a movement for lifestyle change and encouraging members of the populations to join with us to make these changes. Because as the name suggests, we can address the modifiable risk factors.
Thank you. Member Nakari, a follow-up, and then Member Mohit. Your mic, Member Mac, I think your mic is on. Yeah.
Okay. Since you recognize so astutely that mostly our African population are targeted by hypertension, I know you do not drive policy, but have you informed the ministry in the last how many years that there should be some public awareness programs targeted towards those African populations that are affected? I haven't seen any.
Sure. Chair, through you. So, remember, as the CMO would have said, we have engaged a behavior change consultant to assist us with our corporate communication, with our communication strategy, in terms of looking at maybe doing some more targeted messaging. So we would have, and both CMO and Dr. Clapperton spoke about the TT Moves banner and what it speaks about lifestyle change, exercise, healthy living, etc., eating,
Sorry
etc.
to interject, but that started this year.
Well, actually, no. It was relaunched this year. TT Moves has been around for the last
2019.
Yeah, right. But I take your point, and as CMO said, we are looking at doing some more targeted messaging in terms of looking at those key populations and maybe modifying the messages to meet those populations. So that's something that we're actually actively looking at right now and doing that.
All right, thank you. Member Mohit.
Thank you, Mr. Chairman. And I just want to look at the submissions a bit in terms of questioning the National Steering Committee. In your submission, it mentioned about the formation of a National NCD Steering Committee on April 18, 2023. What has the Steering Committee done since its implementation on April 18, 2023? And I want to go a little further. Is the leadership of the ministry, are you all pleased in terms of the performance of this committee thus far?
Thank you. I'll let Dr. Clapperton speak to the work of the committee to date.
Okay. So thank you again through the chair. So the National NCD Steering Committee was formed in April 18th, 2023. And this is a committee that has representation from members of the Ministry of Health and also non-governmental organizations. It's has representation that is across the board. And thus far, the committee has discussed and proposed a communication strategy, which is geared towards, again, behavior change, and this is as it relates to the non-communicable diseases. The communication strategy that was proposed and developed by this committee is currently being reviewed by our behavior change specialists to further strengthen the approaches to this strategy. In addition to this, thus far, there have been additional formation of subcommittees off of this committee to focus on additional key areas as we focus on the non-communicable diseases, one of which would be a subcommittee to focus on the WHO accelerated plan, and this addresses the aspect of obesity, which would speak to childhood and adult obesity measures. And the other subcommittee is to look at an evidence-based approach to clinical practice management for non-communicable diseases.
And in terms of being pleased with the performance of the committee, I didn't hear.
Yes, well, in the short space of time in which the committee was formed, I am pleased with the output of the committee thus far.
Mr. Chairman, an additional question. To those of you present, in terms of behavioral change and the steering committee and its goals and objectives and how you get the population to buy into it, or those who face issues with these NCDs, in the public health system, there's a long waiting list. It's outlined on page 23 of your report. So you have a long waiting list, but you are trying to get persons to buy into behavioral change. How is the ministry, in terms of all of your departments, dealing with this issue? Because on one end, you have a frustrated population listed, are waiting to see what's really wrong with me, how do I deal with what's wrong with me, how do I change my lifestyle, and then on one end you are preaching behavioral change. How are you dealing with this long waiting list?
Sure. Thank you, Chair. So remember, So you spoke about two things there. One is screening, in terms of persons knowing their status, and then the issue of treating with it if they do require linkage to care. What I do as the respective CEOs speak to what the RHs are doing at that level, because that is where the issue of service delivery really happens, at the level of the RHs. So I'll let the four RHs maybe just talk a bit about what they do with their respective RHs.
Thank you, PS. In terms of the Eastern RHs and all RHs strategies to address the issues that we are facing, and I'll speak specific to Eastern, we have a very comprehensive primary care approach, and it speaks to a lot of health education and health promotion in order to ensure that the population takes charge of their health. We have at the Eastern RHA several programs that we execute through our school health team, our health education team, our community wellness groups, chronic disease support groups, and we are participating actively in all initiatives under the TT Moves banner as well to target our population in the Eastern RHA.
Mr. Thomas?
Well, I want to begin by saying that this ultimately affects the congestion in the emergency department. So we ultimately began there. We would have noted, so for example, if there are persons with chronic diseases, they eventually, if it escalates to a point where they get very ill, they ultimately show up in the emergency department. The net effect is that we have inherent capacity at the emergency department, which is one of the reasons why we would have started there with certainly one of our initiatives, to target those persons who are recurring, what we call revolving door patients in the emergency department. So if you show up in our emergency department at Eric Williams primarily more than once within 1 month, we show up at your house. So we basically have a program called the In Touch program, which is run by our liaison unit. And so from a social determinants of health, etc. So they go in, they verify, so a doctor shows up with a nursing team, and we verify what are the reasons. And so usually they may not be taking their medication. You'd find a bag of medication in their houses, they're not taking it. They need consultations for pharmaceutical consultations to remind them of the importance of taking the medication. So we started there. However, we also engaged what we call the Walk the Talk program, which was a primary care initiative where we engaged churches, temples, and mosques in the communities. And so on a Sunday or a Saturday, we would go and do preventative medicals for the entire congregation. And that is across the board. We're at, so far, 39,000 patients. So we walk into your church, temple, or mosque with a team of doctors and nurses, and we do full preventable medicals for the entire congregation.
But if I could just interject, based on the question posed by Member Mohit, and I understand her question, because a lot of the time, while you may have the services at the hospital to deal, and your stated intention is prevention, preventative medication as opposed to treating once the issue becomes acute. When the population has a mindset that I am going to spend 10 hours at the hospital awaiting treatment, the population is less likely to go to the hospital to identify this as a problem to start with, to start treatment. And I think that's the question that the member is asking, because then you have a problem of reluctance to seek medical attention, to identify your problem before it is exacerbated. And while the issue is commendable that Mr. Thomas just identified, what are the stakeholders doing to deal with that issue of the long waiting time, which is a public perception in the public healthcare system? And I'll give you a practical example. I recently took a relative to Mount Hope Medical Sciences Complex. It was a hypertension issue. The person was an elderly person. The intake was fantastic. Upon arriving there, within 15 minutes, blood pressure was taken, general statistics were taken. And then somewhere around half an hour after that and the initial information taken, it took 10 hours to get follow-up treatment. 10 hours. So the person was begging to go home. Take me home. And now there's going to be a reluctance because of that if there's an incident again. What are the systems being put in place to reduce this waiting time? To change the perception so when people walk into the hospital, before they get there, they feel, I'm going to be attended to in a timely manner, because that's part of the perception of the public.
Okay, so I prefer to use cardiology. So for example, we have high incidences of cardiology patients. What we've started doing, for example, is we've disrupted the intake. That is to say, normally we get a number of patients who come from the primary care. We've trained our PCP2s within the communities. So I just want for you to imagine that the cardiology clinic would be filled with a mix of patients. Some of those patients, one group of those patients, are patients who, from the health centers, would receive a card throughout Trinidad and Tobago that says chest pains. They come into the cardiology clinic to be seen. What we've done is we've segregated those patients. So of the volume of patients that normally show up into the cardiology mix of patients, we've segregated those and we are seeing those separately. There's another mix of patients who we've identified those patients as patients who are chronic patients who return or over and over simply to get their prescriptions and so on filled. We've segregated those patients. There's another category of patients that basically would have had heart attacks and basically require to have what we call rehabilitation. We've segregated. So
is all this resulting in shorter waiting times?
Yeah, so what it's effectively done is that we are building the capacity now to be seeing smaller groups of patients with sooner appointments for cardiology. And that is, for example, one of the examples. So it's something that we've engaged successfully and we're expanding.
Do you acknowledge, Mr. Thomas and stakeholders, that there is a problem with waiting time at some institutions?
Absolutely. And so, for example, and I think this one is key, we've trained what we call our PCP2s in the communities so that a number of those patients who normally would come to the secondary care or Eric Williams now can be seen in the periphery. We've started a pilot with Dr. Cummins that had been running, and now we've seen the need to expand the training further outward to all health centers. That training started 3 weeks ago, and so basically when that training is completed, we will be able to devolve a lot of those patients who normally come into the center. The reason for the wait is the sheer numbers of those persons who attend clinic on a monthly basis, on a daily basis.
Mr. Chairman, before we move on, can we be provided in this committee with, let's look at cardiology in terms of angiograms. What's the waiting list like for angiograms at the different RHEs? Or if you can give an accumulated figure across the board.
Yeah, true. Can we provide that in writing to you, member?
If you can put it in writing,
Yeah,
sure. Mr. Chairman, if I can move on
Yes,
to my second
yes,
question. Looking at the wellness festivals, the introduction of wellness festivals. Considering prevention strategies, the submission stated that health and wellness festivals are scheduled to be held by each regional health authority. The first Health and Wellness Festival was hosted by SWRHA on August 26th of this year. Can you provide some information for us as it relates to the turnout for this initial event? And in addition, based on the first Health and Wellness Festival that was hosted by SWRHA, can you determine what can be improved or in terms of giving us that information for the upcoming festivals of the other RHAs?
Sure. Thank you, Chair. So I'll let CEO Southwest give the feedback in terms of that first initial festival. And remember, we've actually held 2 others subsequently. We've had one at Northwest and one at Eastern. So I'll let those CEOs also maybe just give a little feedback in terms of what occurred at those festivals. So we'll start with Southwest.
Sure.
Okay, thank you, Chair. For the Southwest Regional Health Authority, we would have conducted it on the 26th of August from 8:30 a.m. to about 2 p.m. We would have seen from our data about 575 persons accessing services within that relatively narrow window period. And that the Health and Wellness Festival, there were a lot of successes in our view, where we really collaborated based on the program design as directed by the Ministry of Health with input from all the RHAs, because we want to have universal access. When the other RHAs came on after Southwest, was to focus not only on a health fair, which is a typical norm, but a wellness festival. All age groups were targeted, from children to elderly. All facets of the healthcare spectrum in terms of screenings and mental health and stuff were arranged, and also we partnered with a lot of groups, whether it be other state agencies or other non-governmental organizations, offering what we would like to call other determinants of health, social determinants of health. So we had Public Health Inspectorate, we had Arrive Alive, we had the typical screening entities, we had culinary groups that would show ways to prepare healthy food. We had mental health as a focus, we had blood donations as a focus, and really we had also embracing the culture of Trinidad and Tobago, where it was done in a sort of convivial atmosphere with live music, media houses covering the event, and generally an ambience where you simply, it's almost like you're walking in a street fair, and you're basically attending different booths, and the staff man in the booths are able to give you advice, health promotion and health education, and you could walk with your entire family. We had bouncy castles and all of that. So that sort of model is that we want to encourage the population to have a positive view towards health and a positive health-seeking behavior. And then even there are persons who were screened and had abnormal readings. There's the linkage to care concept, where we were able to refer you back to our regular mainstream services in the following week in order to get follow-up. So that it's a good entry point to encourage persons that health is not something to be afraid of. If you have risk factors, whether in your family history, get to know your numbers, and therefore the system can send you to the areas of care that is required. So that is what was designed, and we would have considered it a success, and then the other RHAs replicated thus far.
In terms of improvement?
Improvement for us, well, it was logistics. What is the venue was from 8 a.m. to 2 p.m. We would have liked it to be longer for the entire day, but at the time of the year, a lot of venues are competing. Remember, this is also post-COVID as well, so a lot of venues are getting back to their regular business, and therefore anytime from August to December it is a bit competitive, at least for the Southwest Regional Health Authority, with the venues that have that space and caliber and weather permitting as well. So we had some indoor areas and outdoor areas, but apart from that, we found that the patronage was very good, and we actually had persons outside the Southwest catchment coming to Southwest Regional Health Authority to avail of services, and I believe other RHAs would have that same experience. So the universal access concept was a plus for us.
Just before Member Mohit continues, I neglected to allow the other 2 RHAs to give a report on the issue we raised earlier on with waiting times heading into the emergency room and other services being offered.
Okay, yeah. So with respect to wait times, yes, there can be challenges in the emergency department. So in terms of the health-seeking behavior concept, which is what Southwest is mindful of, our health centers provide health education, health promotion. There are walk-in services at the health centers as well as scheduled appointment services. Generally, Once persons are well managed, once they manage their chronic diseases with their family support and their own individual education support, generally persons have a seamless experience at the level of the health centers. It is for those sub-cohort of persons that are poorly controlled, that either have frequent repeat visits or that they do not seek health care, the natural history of disease may let them land up in the emergency department with a critical illness. In the emergency department, there is a triage system. If you're life-threatening motor vehicle accidents, or life or limb-threatening injury, severe heart attack or stroke, you are attended to really within minutes, seconds to minutes. You find that the concept of wait time are persons who are not that critically ill, what we would call level 3. Those are persons who are alert and ambulant, but they do have ailments that would require them to be warded. As you said, Chair, the triage time is generally quick and efficient. The Southwest experience on average 10 minutes. You do then start to get lengthening of times when you have to do the necessary tests, whether they be blood tests or whether they be imaging tests, to really get a diagnosis before admission to the ward. Average times are about 4 to 6 hours on average. Areas for continual process improvement involves communicating with the patient, let them know this is the step that you are at present, this is the next step that you need to go to, and also give caregiver support. So that occurs. The average length of stay in the hospital is generally about 4 to 5 days for most conditions, and therefore the other weight that perception of persons have is when you're discharged and you have to go to specialist outpatient clinics. Specialist outpatient clinics, there is a demand for services, more specialized tests, follow-up, definitive corrective procedures. But in the context of the discussion today, we do not want the population to reach to that end of the spectrum. The first end of the spectrum is that we have health centers. Southwest has 31, from Icacos to Freeport, from Tabaki to Maruga, accessible, as well as you have district health facilities that also have primary care. One final thing I'd like to mention before I hand over to my colleague is that even in the emergency department, because yes, we would say that all those areas you do not have wait times, except possibly in the ED, what we have found in the ED is that on average, about 1/3 of persons who come, even with chronic disease, they are not going to be admitted to the ward. It is better that they would have sought health-seeking behavior at the health centers. And what we do is that even in the emergency department, there is a system where when we refer you, before you leave, you actually get to see a doctor who actually tells you that, yes, your ailment could be treated at home. You do not need to be admitted, but these are the health centers that are closer to you and that you can get the requisite service there and follow up. So we do recognize that the advertising, or not so much advertising, but letting populations know of where you can access health services in the primary care is still a process improvement, and the ministry has spoken about the behavior change communication in that regard to raise public awareness. So that has been the experience of Southwest to date. Thanks.
Is there one more person?
Thanks, Chair. So the context of Northwest Regional Health Authority is unique, and we have special challenges. Not to reiterate what my colleagues would have said in terms of triage times, needing to improve primary care and so on. Northwest challenge has been, after the earthquake, we moved from approximately 500 odd beds to approximately 110, 120 beds at the Port of Spain General Hospital now, which is our major accident and emergency entry facility. So you're looking at bed space to be able to move persons from out of accident and emergency onto the wards, and you're looking at having almost a 300% reduction in your bed capacity at the hospital. It means that persons stay longer in the accident and emergency because we now have to actually discharge persons to be able to get a bed. We are almost at 100% capacity at Port of Spain General Hospital.
How is that impacting the quality of health care?
Say again?
How is that impacting the quality of health care?
Well, honestly, Chair, it would have impacted adversely, but I'd like to speak about some of the measures that we've put in place.
What are the elements of adverse impact you can share with us?
Well, waiting times, obviously. For patients will have to stay in the accident and emergency for extended times on trolleys and so on, when in the past they would have been admitted in a timely fashion to the wards. But one of the things we've done is to open a 60-bed facility at the St. James Medical Complex that we use as what I would call a spillover facility for Port of Spain General Hospital to assist with that capacity challenge that we have now. We've gone on a program also of what we call revitalization of primary care, and you would have heard my colleagues speak about the fact that we have a triage system, and if we improve the quality of the offering at primary care, many less or much less persons would actually come to the A&E in that
I know
regard.
you're data-driven. You said there was a 300% reduction in the bed capacity, which resulted in people, in patients, seeking care, spending time on trolleys in corridors, etc.
Yes.
We've heard those reports. How much has that impacted mortality rates with people seeking treatment? Because I'm presuming 300% is a lot. There would be some of those patients who may need critical, urgent care, and they're in a corridor when normally they would have been triaged into a more appropriate care scenario. How much has that impacted mortality rates, if you can share that data with us,
Chair,
if at all?
Before CEO continues, just to give you a picture of what was happening. So when we lost those beds, inherently the system caters for itself to some extent. So what happens is the next closest point of call is Eric Williams. So you would find that the patients that can't be seen at Port of Spain will go to Eric Williams. There's an existing relationship between the directors of health, between two institutions, so that if they get to that critical point, the PMOI gets involved as well. There's shuttling of people between the A&E and Eric Williams, as well as Port of Spain General, to ensure that that doesn't happen. St. James has an A&E as well. Arima General Hospital, post-COVID, is now getting to its full complement of staff, and their services are picking up as well. So even within Eric Williams, and CEO for North Central could speak a little bit more to it, they have begun to declutter Eric Williams. So there's a knock-on. Port of Spain, Eric Williams, and then Arima. So Eric Williams patients who are stable patients, stable medical patients, are now going across to Arima.
So are you saying it has not impacted patient mortality?
I don't say that, well, in terms of mortality, in terms of patient flow and weight, that's how we have aimed to deal with it. In terms of saying with data to back it up, I can't say either way. In terms of, it has to be a case-to-case to say whether it has impacted mortality or not.
And those kinds of analyses are not commonplace?
In terms of the CETA system, the way, and Dr. Amor would have begun to describe it, CETA system deals with the most critically ill first. And we deal with those that are type, what we class as class 1 and class 2, those are imminent risk of death. Those will be taken care of immediately. Class 3 and 4 can be seen at the district health facilities as well, which St. James has one, and other DHFs, and stabilized and then dealt with at home and sometimes warded later on. So we avoid mortality in that way.
All right. Monroe.
Thank you very much, Chairman. And I must start off by saying thank you very much to the team from Ministry of Health for making yourselves available this morning to answer questions of this committee. Let me start off by asking, in your submission, you would have mentioned TT Move's behavior change campaign. I want to find out this morning, what is the status of this campaign, and would you say that the campaign or the Ministry of Health is achieving the results desired or expected from this campaign?
Good morning, Chair, Member. Thank you for the question. So the TT Moves campaign is currently in a process where it's being re-energized from the first instance in which it was launched. We have added the new tagline, a movement for lifestyle change. And yes, we are catering to encourage members of the public to change their behavior, make healthy choices in terms of their dietary measures, and to move more. But we must recognize that these changes will not come overnight, and it is a challenge that we will all face. But as best as we can, under the umbrella of TT Moves, we can continue to encourage persons to move them along the stages of change. We do recognize that persons within the population would be at various levels, those who would already have made some changes, those who are contemplating making these changes, and we try to make the behavior change or TT Moves campaign as broad as possible to cater for persons who are at the various levels in their stages of change, and we also try our best to make it as simple as possible. So currently, under the banner of TT Moves, there are 3 things that we have started to drive home in terms of the messaging. So we encourage members of the population to increase their daily intake of water, to increase their daily consumption of fruits and vegetables, and to encourage them to increase their levels of daily physical activity. And I dare say we would like to add a fourth soon, which is to know your numbers, because we do recognize that a number of the NCD risk factors, in particular hypertension, are asymptomatic. And we have a lot of persons walking around not knowing what their blood pressures are, not knowing what their cholesterol numbers are. And under, again, the banner of TT Moves, these TT Moves Health and Wellness Festivals are opportunities which we provide access to care in the community for persons to have that linkage to care and have screening of their blood pressures, their cholesterol numbers, and be more familiar with their health numbers. So TT Moves is currently being re-energized in this way, and we look forward to the support of all members of the population as we encourage everyone to move their wellness journey forward.
Oh, just in terms of the measurement, so you would have noted in our submission that we would have provided data from STEPS of 2011. There would have been a global youth survey as well, I think it's 2015. We are going to repeat the STEPS survey, which is the broadest, it's a PAHO coined term, STEPS, and it's the broadest type of survey to do from a health perspective. So that is going to be repeated. We hope to complete it within fiscal 23-24, that period of time. And it will give us a very good idea of what has changed between 2011 and present in terms of the demographic of the patients, hypertension, diabetes, eating habits. In addition to it, we are doing a food consumption survey with partnership from various stakeholders, including the UWI and PAHO. That is again due to be completed in the third or fourth quarter of calendar 2024. And those will give us very good indicators as to the successes of various initiatives that would have occurred over the past 10 or 12 years, thereabouts.
Thank you. My following question is based on some information that was made available by you all here this morning. Given the importance of managing NCDs nationally, I would like to know, is the Ministry of Health targeting or monitoring our kids at schools? And if no, would this be considered to shape the lifestyle trends at an early stage in our young men and women's lives?
Thank you again for the question. So with respect to the Ministry of Health's approach to addressing the issue of non-communicable diseases, we are taking a life course approach to addressing the issue of non-communicable diseases. And this begins in pregnancy in utero, also with breastfeeding initiatives. Dr. Surjit Singh can speak further on these initiatives moving forward. And as it relates to children and adolescents, there have been several initiatives as well where exercise equipment was purchased and placed in primary and secondary schools. There was also the implemented ban on sale of sugar-sweetened beverages in schools in 2017. So there have been several initiatives in the past for that directly targets children and adolescent populations, and there would be more in the pipeline to come.
Sure. My portfolio will be related to the care of women in pregnancy as well as the newborn period, our children. So we have a very innovative, out-of-the-box sort of approach to this NCD problem that we are experiencing. We are actually trying to prevent NCDs before you are even conceived. So that's a novel approach. We're actually targeting our chronic disease patients, for example, and our potentially pregnant populace, so reproductive women, to ensure that they seek healthy behaviors and they enter pregnancy well to prevent some of the issues that may develop during pregnancy. So that's the preconception part. So for example, if you are in a chronic disease clinic and you have diabetes from birth, we have patients like this, or you have a chronic disease type 2 diabetes or hypertension, we want you to be well controlled before you get pregnant. But then since 2018, we had a policy change at the Ministry of Health where we introduced clinical guidelines for the first time to manage diabetes in pregnancy as well as high blood pressure. But this novel project, it included having a standardized approach to how we cared for these patients who develop diabetes in pregnancy. But what we did was we screened And from now, since 2018 onwards, we've screened every single patient who attend our clinic, both in public and private, for diabetes, which wasn't done before. This is diabetes in pregnancy. So we pick up patients who may develop diabetes in pregnancy for the first time, or those who may come into pregnancy not knowing they have diabetes. We take special care with standardized protocols and so on. We provide glucometers for these patients. We give them consumables. They take home those glucometers and can continue to use them after pregnancy. By taking care of these patients during pregnancy, we can actually make them have lifestyle changes that will prevent diabetes both for the mother in the long term, because they have a 50% chance of developing diabetes, and the infants are also, we're going to reduce the chance of that infant developing diabetes in the future. And just to add on, we created the breastfeeding team at the Ministry of Health. In the year 2018, we formed for the first time the National Breastfeeding Coordinating Unit. We created policies for the first time. And we are really doing a lot of work on breastfeeding, because that, if we encourage our population to breastfeed exclusively for the first 6 months, that's also going to reduce diabetes in these mothers as well as those children in the future. We may not be around to see all these benefits. That's a long lead project. But this is going to make a dramatic reduction in the years to come. That's just some of the work we're doing.
Okay, thank you. My next question is, your submission stated that a key area for gestational diabetes management program was to provide at-home blood glucose monitors to 3,000 expectant mothers, and to 218 would be used in antenatal clinics at various health clinics at our various health facilities. Can you confirm whether those were received?
Yes, and that's part of this larger project. It was an IDB-funded project where we engaged consultants from the Helen Bhagwan Singh Diabetes Education and Research Foundation, DIRPI for short. And with this project, with an IDB loan, we had different elements of this program, which involved training healthcare workers, training our patients, as well as providing these glucometers. So we've so far procured 3,000 plus glucometers, and all of the glucometers have been distributed to all of the health centers, all our antenatal clinics, and we are still in the phase of distributing the glucometers. So we actually have another system, which is the perinatal information system, where we have over 40,000 patients now entered in that database, which provides research and other data. From that, we have found at this time approximately 1 in 9 to 1 in 10 of our patients in pregnancy are diagnosed with diabetes in pregnancy. So we are in the process of distributing the glucometers. So that's a long project that is probably going to be happening over the next couple of years. We have enough glucometers for that group of patients.
Is it that you also provide the testing strips along with them and they have replacement options?
Absolutely. So we provide enough testing strips. We have all of that catered for in the project, with M&E built in as well. So in time, we'll have the data to supply with the outputs of this.
Thank you. Also, I saw stated in your submissions, physical activity equipment has been procured and delivered to schools throughout Trinidad and Tobago. Please provide further information as to the type of physical activity equipment which were delivered, and also, could you also consider the outstanding equipments to be delivered to special needs schools? Please indicate when this will be delivered. Thank you.
I don't have the specific equipment with me. I can provide it in writing to you, member. With regard to the special needs schools, we expect to complete deliveries of the outstanding equipment during the second quarter of calendar 2024.
Just you may or may not have, and you can supply if you don't have in writing, but this submission that physical activity equipment has been procured and delivered to schools, how widespread was that delivery? What schools were involved? If you have the cost of that equipment, when can the full complement of the equipment be expected to be delivered?
Sure, Chair. So the amount that we spent on the school equipment is 27.9 million TT. the number of schools that we've targeted, 623 schools. We've delivered at 611 schools so far. That is broken down among 479 primary schools, 134 secondary schools. Yeah, I don't have the specific equipment, but we can send that.
And those schools were primary and secondary, and they are special ed teachers assigned to supervise the use of this equipment? Is it that kind of equipment?
Well, so you'd have, I think most schools have a physical education component, so it would fall under that area.
And is there a maintenance program for this equipment? Because you know we love not to maintain in this country.
So I think Ministry of Education may be best placed to answer in terms of that. So what we would have done at the ministry, through the IDB loan, we would have purchased the equipment in partnership and in consultation with Ministry of Education and provided the equipment to these schools through Ministry of Education. They would then from there take it over in terms of the programs and the maintenance. With obviously, in terms of the programs, if they require any sort of technical support from the ministry, we are obviously providing that sort of support.
Thank you. Just before we go to Member Naked, in terms of the TT Moves Behavior Change Campaign, Member Naked would have indicated it started in 2019. It probably would have had to stop due to COVID lockdowns. Would that be correct?
It's slowed down.
It's slowed down.
Yeah.
How have you been, and how do you intend to continue measuring the impact of that?
CMO would have mentioned the STEP survey, and that's one of the ways we'll measure the impact of the TT Moves campaign. I think both Dr. Sejus Singh and Dr. Clapperton also said that this sort of change it's not an overnight change in terms of looking at a person's lifestyle and the health outcomes. That is literally years in the making. So in terms of looking at the ultimate impact, that is something that is done over a course of years. To see
more longitudinal data collection.
Yeah.
Member Naked, go ahead, please. Thank you.
Chair, before we go on to the screening and clinical management part, I just have a standing question for Mr. Davlin Thomas. You mentioned something that sounded quite commendable about if there was chronic people coming to the health centers on a regular basis. After the second visit, if you realize it's something chronic, you would go visit them. Do you have any very valuable data related to that?
Oh yes, we do. In fact, so far we've seen over 3,000 persons. And
over what time period? Over what time period?
This is just as at January 2023, 3,400. So it's more now.
It's more?
Yeah.
Okay. Chair, can we get that? Chair.
Can you provide in writing the data on that, please? I'd appreciate it. Thank you. Go ahead, Member Naked.
Your health initiative for men was launched, according to your submission, July 8th and 9th, 2023. Will this be an annual endeavor?
Thank you for the question. So the Health Initiative for Men was launched and held over the weekend, July 8th and 9th, 2023. It was a collaborative effort between the Ministry of Health and all regional health authorities. We did have, and we are encouraged by the overwhelming response, because within that weekend we had over 4,000 men turning out and getting screened. And as you know, prostate cancer is one of the leading causes of mortality for men, so we are very heartened and encouraged, and we do hope to continue these efforts annually.
We go on to the tobacco control and regulation. Your submission mentions the full implementation of graphic health warning pictures in September 2022 on the packaging and labeling of all tobacco products to deter tobacco use. Can you determine whether this implementation had any impact on tobacco usage?
Thank you, Member. I don't think we've gotten any empirical data in terms of to determine exactly how much of an impact it has had in terms of tobacco usage. So to answer your question, we don't have that specific data at this point.
But again, the STEP study has a full component that is detailed for tobacco use in terms of new users, age groups and all of that. So once we have that data, we can provided later on as well. Empirically, the manager of tobacco control, the graphic warnings were really to deter people from even starting in the first instance. Persons who are already addicted, and we know tobacco to be one of the most addictive substances utilized. It's extremely difficult to stop, and it usually requires transitional models of change and clinician-led interventions. But the graphic warnings, hopefully, with time, will dissuade new users from actually taking that first use.
Has the ministry considered liaising with the Ministry of Trade to determine if, in the absence of this data, because I mean, it's one thing to initiate a graphic warning campaign to deter people from tobacco use, but it's something else to actually get the data to see if the campaign is working. And one of the ways we'll find out if the data is working is if people won't be importing a product that's not being bought. So is there any collaboration with the Ministry of Trade to see if there's a reduction in the importation of tobacco products, or any data that could suggest that tobacco products are being used more or less in the country? Because to me, that's when you realize if the campaign is working or not. In the absence of that, we're just shooting in the stars.
So that's something that we can definitely speak to Ministry of Trade about, Chair. That's a suggestion we will definitely follow up on.
Is there any data regarding the use of tobacco in teenagers? Because that is the main target by many tobacco companies. If you cook them young, you have them for life. I have a gripe about tobacco, so you'll excuse me.
Provided some data to the committee on tobacco use. I'm just trying to locate it. I can't find it. Sorry.
Thank you. Go ahead, Member Hackett, while they seek it.
Yeah, so. Right, so I think the question was, can you advise the committee on the current trends in tobacco usage in Trinidad and Tobago? And according to a 2017 WHO Global Youth Tobacco Survey for Trinidad and Tobago, results for tobacco use indicated 14% of students, 17.3% of boys and 10.8% of girls use tobacco products. 11% of students, 13.6% of boys and 8.6% of girls smoke tobacco. 6.7% of students, which equates to 8.6% of boys, 4.9% of girls smoke cigarettes, and 4.1% of students, 5.0% boys, and 3.2% girls use smokeless tobacco in the submission on page 18 of 20.
Well, I'd like to address what I consider, and I heard the chairman allude to it, I don't know if it was in JSC or in the Senate, the problem of alcohol. We focus on tobacco, but alcohol is, it's unbelievable, the consumption in Trinidad and Tobago and the effects that it has on communities. I would like you all to address that as we are talking about tobacco, the alcohol usage and the advertising of alcohol within certain communities in Trinidad and Tobago, especially the East-West corridor, in Tinapuna, St. Joseph, Champlain, Lavantil, Mova. You see these massive billboards that we don't see in Bayshore and Goodwood Park and other communities. Why is that? And is there any attempt by the Ministry of Health to circumvent or to stop that completely? Because I see it as unfair to the communities of the residents of those communities, where they have this massive billboards of alcohol in especially poor and disadvantaged communities. Why is that?
Thank you, Chair. So, remember, in terms of the work that the ministry is doing with regard to alcohol consumption, there is a unit within the Ministry of Health, NADAP, National Alcohol Drug Prevention Program. So, NADAP works with various stakeholders in terms of various addictions, alcohol being one of them, in terms of how can we prevent alcohol abuse and consumption. So NADAP is that agency within the ministry that looks at that particular area.
No. Okay, I understand. I don't want to stay on that point, but I'm talking about how alcohol is sold and advertised within certain communities within the country.
So
has the Ministry of Health addressed that?
Yes, so Senator, we will certainly take it on board. I will discuss it with NADAP, and we will see. It sounds to me that there may be some need for legislation to deal with that in terms of advertisement, and certainly on the softer side, some consultation with the persons that advertise the alcohol for sale in those particular instances. So I will bring it to the attention of the NADAP coordinator, and we'll treat with it.
Thank you. Considering the sensitization sessions that were conducted with 70 sellers of tobacco products in over 5 countries on the requirements of the legislation, illicit tobacco trade, and the effects of smoking on the health and well-being of the population, can you determine the impact the sensitization sessions had on the communities where they were held? It's from your submission, page 52. On the Ministry of Health.
Sorry, Chair, to you.
Page 5.
Page 5. Remember, what was the question again? Just remind me, please.
Pardon?
The question? What was
the question?
Yeah.
Can you determine the impact the sensitization sessions had on the communities where they were held? They were conducted in 5 different countries.
These are the consultations with the 70 sellers of tobacco products that you'd have provided in information. And in these 5 countries, are the requirements of legislation, were there consultations or discussions on that in terms of the trade in tobacco products and the impact of smoking on the health and well-being of the population, specific to Trinidad and Tobago? Would you have had information on that?
Sure. So I will get that information for you, Member through the Chair, from our manager of tobacco, but this would have spoken specifically, as it says, to the sellers of tobacco as opposed to the consumers. This is where, when we were developing the graphic warnings and fully rolling out the legislation, we would have sought to engage the sellers so that they are aware of what's coming, to sensitize them to what the ministry has been doing. All right? But I will get that data in terms of the...
So just as a follow-up to that, is it that the ministry's committee on this is focusing on possibly amending legislation to deal with tobacco packaging and tobacco advertising, etc., with a view to reducing the use even more or targeting of certain populations? Is that the intention of this?
Well, I think we premature this.
If I may, the sensitization sessions will post the graphic warning coming into being. The manager would have done sensitization sessions with the sellers to ensure that they were aware of the legislation and they knew the penalties therein so that they could abide by it. And then when we did the monitoring and evaluation thereafter, because they have inspectors in that unit that go out to all the sellers, they go out to the retail outlets, wholesale outlets to do inspections to ensure that they comply. They wanted to go up front to them, tell them, look, this is the legislation, it is new, so everybody's aware and we're all on the same page. So when we do the enforcement exercises, you can't say that you didn't know up front. So that was the purpose of it. The other counties were supposed to be conducted shortly thereafter.
Thank you. You have established stress clinics at the North Regional Authority. Your submission, page 6Q2. Is there a particular premise that you decided to establish this stress clinic?
Chair, through you, it's a stress relief center. So the overarching premise came out of discussions with Professor Hutchinson, who is the head of our psychiatry and psychology department. Certainly there was the issue of stigma for mental health engagements. And so we were careful to design an interface that absolved the person as much as we could who approach these clinics of the ubiquitous stigma that exists within Trinidad and Tobago, and certainly the world. So basically, After careful consideration, we decided to call it a stress relief center. On the first prototype, we noted that on the first day, and advertised, indicating to the public that basically, if you engage in stress, you can walk into the center. On the first day, we had over 200 persons, and quickly understood that we needed as not only to expand the inherent capacity at the center, but also to expand the distribution. So that is to say, so we now are at St. Joseph.
No, I commend you for that. Yeah. And upon the recommendation of Professor Hutchinson, who is well known in the field of psychiatry. But this is a question to the PS, the CMO, and Dr. Clapperton. We're talking about NCDs and the prevalence and interventions for NCDs, and it's scientific information, you can correct me if I'm wrong, that high stress levels will make someone more vulnerable to specific diseases or exacerbate the effects of diseases they may have. Is that correct? Has there been an assessment done? Because Mr. Thomas indicated they've created a stress relief center, which means there must have been some information that would have indicated that we have a stress issue in the country. We're not absent of stress, but is there inordinate amounts of stress in the country that is also impacting the health of people and the impact of non-communicable diseases? Can you all comment on that? Is there an assessment done on stress levels in people that may be impacting their health in the country?
Thank you, Chair. So in terms of documentation or an official assessment, I would not be able to speak to that at this point in time. However, research done outside of Trinidad and Tobago would have spoken to a relationship between the non-communicable diseases and mental health, right? And this could be in both directions, as you would have mentioned previously. So persons who have anxiety or stress-related disorders and depression would be at greater risk for developing a non-communicable disease. And similar to this, persons who are diagnosed with a non-communicable disease, for example, diabetes, are at greater risk for developing mental health issues like depression later on. So there is, we are aware that there's a relationship that exists between the non-communicable diseases and mental health. And this is why at the Ministry of Health, in our approach to addressing the issue of non-communicable diseases, we do recognize mental health as a non-communicable disease. So our directors of mental health would have, taken the lead on, projects related to this in terms of addressing issues of mental health.
So it may not be specifically related to measuring stress levels, but certainly the impact on mental health and physical health as a whole, as a holistic approach.
A holistic approach.
Yeah, but just for clarity, in terms of stress is a loose term, right? What we measure is we will measure your blood pressure, for example. One of the things when we do the consultation with that individual who has elevated blood pressure, we'll be taking a history. So we take the history to find out what would be the causes. Could be family history, as you said, non-modifiable. It could be excessive salt intake, could be stress-related. We know about the type A personality that exists. So it's not a defined term in terms of what you measure. If somebody is stressed and all your parameters are normal, your blood tests are normal, your blood pressure is normal, sugars are normal, then it's not necessarily a concern because you're not going to get the complications down the road. But certainly if somebody is having high blood pressure, having elevated sugars, and stress is a major factor that is contributing, then in terms of the clinical pathway that we deal with it, we have to deal with stress. If we don't deal with it and we put you on 4 or 5 different tablets to try to deal with it, nothing is going to change. So we have to deal with the causes, and that's what prevention is. So we deal with the causes first, and then we deal with the symptoms.
Thank you. Just changing gears now. Your submission mentioned the number of persons who have been screened and diagnosed with the NCDs we focused on today, cancer, diabetes, and cardiovascular disease over the past 5 years, could not be readily available due to the lack of an electronic health record, system to track one patient per record throughout the public healthcare system. I remember the Minister of Health during the COVID-19 pandemic announcing digitization of patient records and the ease with which the then COVID-19 vaccination cards would be made available. Could you give us a status update on that digitization of patient records in the country and similar circumstances and similar surrounding issues?
Sure, thank you, Chair. So just in terms of, just to go back a bit to the issue of the COVID-19 vaccination cards, so that was a specific system for vaccine management. So what you're speaking about is broader than that. It's actually a patient's electronic health record, which would include vaccination and patient visits, clinical history, etc. Where we are with that as a ministry level, we are currently in the evaluation process for a health information system for the ERHA. That's for the entire RHA, with the intention being subsequently afterwards to look at rolling out nationally. What's happening in the interim is that each RHA has some element of an HIS and by extension electronic health record for their patients to varying degrees of completeness in terms of how much is actually captured on that health record. The intention is ideally, as I said, once we have the ERHA tender completed and we roll out, we will then have an electronic health record, not just for one RHA, but it's a national record. So if you are a patient in the ERHA and you visit San Fernando, for example, on a weekend and you have to access the health facility there, the record will be accessible anywhere in the country. That is the ultimate objective. As I said, where we are right now, completing the evaluation for the system at the ERHA and the other three RHAs, and Eastern to a lesser extent, already have some element of a health record.
Correct me if I'm wrong, it doesn't sound, is it standardized across the RHAs? Because you said they have different levels of digitization within their own systems with a view to ruling out the national system once that procurement is done. Is there a standardized approach that is undertaken by each RHA in digitizing their patient records presently?
So I'll let the RHA speak to that, but what is standardized, it is the actual medical record, whether it's paper or electronic. So you have a standard medical record, and that is what would be ideally digitized by the respective RHAs in terms of the extent that they will digitize as they go along. But there is a standard.
Could the RHAs comment on that, how far you are with digitization of patient record? Because I'm presuming if that is done, when the national system rolls out, it'll be easier to transfer the information or collate it.
Thanks, Chair. So at the end of the RHA, we do have a pilot system that we'd have started in 2020. It started with our St. James Medical Complex facility, digitizing our pharmaceutical systems and our patient records there. That system has worked well so far, and we've started to expand it to all our health centers nationally. And actually, we also have it at the St. Anne's Hospital and the Port of Spain General Hospital.
So it's all the records are completely digitized in that system?
Where pharmaceuticals are concerned, in terms of the dispensing of pharmaceuticals, we're now rolling out the module that deals with patient registration and so on at the Port of Spain General Hospital.
Are there timelines on that?
Well, I would say by the second quarter in this financial year, we should be completed in terms of the digitization, that pilot project.
Dr. Amor, how far back do these records go?
Currently, we would have had a system existing before, a paper-based system. What we've been able to do is digitize those records. I think we looked at approximately 5 years of records to start, because the paper records are extremely voluminous.
Right. Dr. Amor?
Sorry, Chair, if I may, before Dr. Amor
please go ahead. Sure.
Just in terms of your question, is how far back do we go with digitizing a record? What the practice has been, and the ministry has said, is that, as CEO Blake said, we will go back maybe 5 years, but we don't digitize every record. So if, for example, there are 500 patient records in the hospital, rather than go and digitize all 500 for the past 5 years, we digitize as the patient touches us again. So in other words, when you come to the clinic, we know we're going to digitize your record, because there are patients on the system who may no longer be alive, who may no longer be accessing the system. They may be accessing the system only once or twice, but their record is there. So rather than digitize all the records at once, as you touch the system again, we would then go back and digitize your record.
Thank you. Dr. Amor, I think.
Yeah, at the Southwest Regional Health Authority, we have made strides, particularly in the last 3 to 4 years. We were at a point as of October to have paperless service at our emergency departments. That will be at San Fernando and Point Fortin, our flagship hospitals, as well as the emergency departments in the DHFs. The last one that was coming on board was Princestown. Even though it's in the public domain that we have had a recent incident, we are still in the process of recovery, expecting to resume services in full by November the 20th. So our patient care experience is that when you come in, there's no paper record. Everybody from the clerk to the doctor, nurse, orderlies, everybody has a tablet, and that the software allows, as you enter your data, as the patient moves from one cadre of professional to the next, it is the record is electronically transferred, so that at the end of the day, the staff are well trained and that it's paperless. So that is the case in the emergency departments. The medical records department is also electronic in terms of your block appointment systems. We have also started to do e-discharges, so that from the wards, when persons are admitted to the ward and they discharge to the clinic, you now have to do an electronic discharge. That was in the process of being advanced in implementation. And also, too, we have a concept of e-referrals, where persons who are seen in the health centers, rather than the patient has to come to the hospital clinic to drop off a paper-based referral, several of our health centers are able to send an electronic referral if a doctor has to refer a patient to the hospital environment. So that's respect to medical records. Respect to pharmacy, well, it's electronic in terms of prescriptions, filling out of prescriptions based on that system. It redounds the patient's customer service, it becomes seamless, and it redounds the staff efficiency, and it also has some secondary gains with cost savings and so forth, so you can track a patient in a holistic concept. We also have the lab information system and the radiology information system that's also electronic. And on all our wards where we are now, even though we have done pretty well in the EDs, the medical records and pharmacy, we now have on the wards the hardware capacity where you can actually get your lab results, so that it's processed in the lab, it's electronically sent to the wards and clinics, as well as your radiological images through the radiology software. So each RHA, based on the RHA Act, is mandated to improve the efficiency and effectiveness of care as governed by the board. So with these sorts of efforts, with each RHA, we're now working with the Ministry of Health, because we do recognize, even for us, a limit is if a patient now goes to another RHA, and they need to get continuity of care. And that is the project that we embarking on. Sounds intuitively simple, but it of course is a cultural change with the staff, and of course having that enterprise national solution to move us forward. That's where we are with Southwest in the main with respect to the
just
electronic
before I move
record.
to the other two, and I'm presuming the information or the systems are the same in the other two, would that be correct? So we can save some time? Or are they different?
Some are slightly different.
And just, Dr. Amo, you mentioned an incident that set you back. Would you care to share that with us? Was it a malicious incident?
It was. It was.
So, and you have, because the cybersecurity issue is a big one in Trinidad and Tobago now. Was it well, malicious is intentional. Was it profound in terms of its impact on you?
Initially, it was profound. We had to shut down the network, and we had to turn computers offline. We would have been in an emergency mode internally at our level in order to ensure that, working with national security agencies, we had to scan our network, all the end user devices, and we would have had to rely temporarily on manual backup systems in terms of some paper-based systems as well as some manual backup data. And for us, it's not only patient care, electronic data was impacted, but also to some extent our administrative data. But all in all, with the support of other RHAs, because they would have assisted us, as well as the Ministry of Health with their guidance, we are considered ourselves well on our way to recovery. We have stated in the public domain yesterday and further today as of this morning that we expect to resume our patient core services in full by November the 20th. Some of the systems I described have gotten back online. The administrative systems, we are still in the final processes of those getting back online.
When did this happen?
At 3:45 a.m. on the 23rd of October 2023.
So pretty recently?
Pretty recently.
Have you put systems in place to, was any patient information compromised or accessed and disseminated?
I could advise at this point in time, as advised by TTC, that's the agency that was leaned on the law enforcement. They have advised at this time, at this date and time, that there's no evidence of such. nor have we received any indication that that has occurred. But we are advised by TTSO to do a full investigation, and we have been able to secure our data to safeguard the public interest.
Yes, as a result of that, because we've had the recent hacks of so many entities in the country, how much emphasis is being placed on this in the overall healthcare system in Trinidad and Tobago? Because confidentiality of patient information is, of course, part of your business.
Sure. Chair, thank you. So it's a lot. It's critical to us. So actually, we would have met with TTC CERT and the 4 RHAs last week to discuss, one, the current state of the respective RHAs and their systems, and two, what action can we take to improve the security of the RHAs and the Ministry of Health of our IT systems. The Ministry of Digital Transformation would have also been part of those discussions to ensure that whatever systems we roll out or we implement, we have taken the adequate steps to provide that level of cybersecurity.
Thank you, Member Mohit. Go ahead, please. Thank you.
Thank you, Mr. Chair. Just additionally, PS, you mentioned that, one system, so if patients are to go to any RHA, you have their information. But from what I'm seeing, different RHAs, they're explaining different digital systems. Is it that you plan to merge all at some point and have some, one system where all information can be accessed?
All right. Thank you, Chair. So let me try and explain. I'm not an IT person, so what we're doing, and it treats the concept of interoperability. So you may have different systems, but the database and the data that's captured is common. So those systems can speak to each other. So the intention may not necessarily be to replace the existing system with one system. You may have this system and another system, but they can speak to each other, accessing a common database. So the patient record is what is common. The actual interface may be different, but the data is common.
Okay. I know you mentioned that Ministry of Digital Transformation, they have been involved in your conversations of in terms of the electronic data system for the health system. What about PAHU? Any consultation or communication in terms of technical assistance?
Yeah, so PAHU provides technical support to the Ministry of Health, and also in this case, in terms of our electronic system. So if we require any sort of support, PAHU provides that technical advice to us in terms of best practice, what happens out there. If we require any specific support, yes.
Sure. In terms of, one other question, Mr. Chairman, in terms of your submission, mention what was made of current initiatives, projects, programs that are being implemented within the primary and secondary school systems to increase the awareness among the student population. Can you state for us whether there are any plans to expand the initiative projects and programs for this targeted age group?
Yes. So I think the short answer is yes. The initial campaign that we're trying to launch is a mass campaign to build awareness about NCDs, the modifiable risk factors. But we recognize that really and truly the children are our future as it relates to NCDs and getting a society that is healthy. Hence the reason we have put significant investments in the exercise equipment. But if we put exercise equipment in there and it's not used, it doesn't make sense. So we, as a major partner, the Ministry of Education has been working with us, and really to get exercise is not about schools alone, not about exercise equipment. We have to get the parents involved. We have to get the PTA involved. We have to get the extended families involved. And that's why we said we need all of government, all of society to deal with this issue. Because we can't hold your hand when you're at home. We can't tell you what to eat at night. Your parents have a big interest. We can't tell you what to buy at the grocery stores, aside from putting legislation in place to deal with certain aspects of it. So it requires all of us. And the children are really where I think the future is at, as it relates to getting our country to a place where we are a healthier society on the whole. So our target will certainly be at the children going forward over the next few years. And it's not a short lead project. We're talking about decades. To see a healthy population, we're talking about 10, 20 years into the future. So we're trying to put the seeds in place now so that in 10 years, we don't have the cluttering of the A&Es. Because what we're seeing now is a symptom of the NCD epidemic, which has started 20 years ago. If we don't stop the epidemic, and our greatest weapon to stop the epidemic is primary prevention, If we don't stop it now, in 20 years, I guarantee, even with a new 500-bed tower in Port of Spain, a new ARIMA, a new Sandy Granny Hospital, we will not have enough bed space.
So how much emphasis is being placed on the diet, children?
So I think the diet is one of the
because
greatest.
exercise is one thing, but if you're putting in the junk.
I mean,
and just sorry about that, but a large part of it also is the education about
that's
fast
right.
foods.
I think
and the
they all
impact of
go
fast
hand in
foods.
hand, right? Creating we have an environment generally that is obesogenic. So we have the factors that lead you towards being obese. We have to do anti-obesogenic environments, which speak to all of it. It speaks to diet, it speaks to exercise, but to which part each one contributes is different. But generally to a well individual that is healthy in all aspects, including mental health, because mental health is considered a great part and parcel of it, and it goes both ways.
Yes.
As you mentioned, the primary and secondary school, what's the level of synergy with the Ministry of Sport, especially primary and secondary school? What level of synergy you all have with the Ministry of Sport?
With education or directly with
Well,
Ministry
you're
of
talking
Sport?
about getting that awareness program and having that kind of activity.
So as I said, it is a whole of government approach, and Ministry of Sport is one of our greatest partners in addition to Ministry of Education. So both of them I think would be, as well as Ministry of Agriculture, will be our lead agencies that we collaborate with.
So they are you are in
yes.
partnership. You're not moving in silos. You are in partnership with the Ministry of Sport.
No. Actually, beyond the NCD committee, there's a vision to create a tier above that in terms of an oversight committee, which will have the critical ministries as well as critical NGOs working together, PAHO and CAFA, so that we bring all of it together. And that there's not, as you say, this silo mentality, and all of us working to try to create a society that's healthier. It requires everybody. I mean, we can't leave sport out of the mix. And you will know better than anybody else that sport is an integral part of creating a healthy society.
Well, then, any identifiable programs that are in place right now with the Ministry of Sport?
Well, they might be better placed to speak about their individual programs rather than us. But certainly they are a major partner for us.
Thank you, Member Mohit. One more question and then Member Monroe. No, okay, Member Monroe, go ahead, please. Thank you. Thank you very much for your speech.
Thank you very much, Chairman. My next question, maybe to the PS. Your submission would have stated the cost of dialysis, however, did not mention the actual cost of insulin. But what I would like to know is what's the annual cost in managing NDCs? NCDs, sorry.
Thank you, Chair. Remember, you gave us a difficult question. We'll have to, I don't think we have that figure, member, because the cost of managing NCDs, it includes the cost of the clinicians, the cost of the equipment, cost of the pharmaceuticals, the non-pharmaceuticals, all the consumables. I don't think we...
But I think the question comes from a statement attributable to the Minister of Health, who indicated it may be in the budget or in another forum that the cost of NCDs is one of the most significant costs borne by the Ministry of Health in intervention and the treatment. So maybe we could supply it in writing if you can.
Sure. Yeah.
Thank you.
Go ahead. Thank you, Chair. Also, your submission mentioned shortcomings in the outpatient services as it relates to treatment available for persons with diabetes, heart disease, and cancer. What has the ministry done to alleviate such challenges? And also, what do you recommend can be done to alleviate the current shortcomings in your outpatient services?
Through you, Chair. Member, could you just point me to the page, please, so I can respond?
Page 15, question 6.
1 second. Okay, great. Thank you. So we would have identified at least 3 of the challenges. One would have been as I see it here, the lack of an electronic system to manage the appointment system, ability to provide timely diagnostic results, and you need to expand the DHP program. So CEO Southwest would have spoken, and it's the same for the other three RHAs, where they would have sought to implement that electronic system for appointments. That has started. As I said, it's varying degrees at the respective RHAs. We've started doing that. Diagnostic tests, those are being done. We have point-of-care testing done at the primary care level. 2, where you have tests at the hospital using the lab information system. Those diagnostic tests, the results are available to the clinicians a lot faster so they can take action. And with regard to the third point about the district health visitor program, in 2021, the ministry would have graduated in partnership with the University of the West Indies School of Nursing 99 DHVs. These are nurses who have been trained in the DHV program, and they have all been absorbed as a DHV in the respective RHAs at the 4 RHAs. So we have increased our complement of DHVs. Well, there are a lot of vacancies by 99 persons. So we have, from a human resource perspective, addressed the shortage of DHVs as it stood. So those are some of the things that we would have done at the ministry level. If you want, I can get the RHAs to maybe speak a bit more about what they've done at their respective RHAs.
Thank you.
Yeah.
All right, at the Eastern RHA, similar to what my colleagues would have indicated, we do have an electronic client records or registration system. We do have the lab information system and our pharmacy information system. And as PS indicated, the Eastern RHA is the pilot for the national HIS. So all our systems will become interoperable once that procurement is completed. In terms of timely diagnostic results, we at the Eastern RHA have the requisite systems in place out at primary care as well as secondary care to ensure that those results are filtered into our clients in a timely manner. And of course, the human resource capacity of the authority is addressed currently, and when the district health visitors comes out, that will also increase our capacity.
With regard to items 2 and 3 in particular, the ability to provide the timely diagnostic results as required, we not only engage optimizing the time that we were able to produce a result for a diagnostic test, particularly lab tests. What we did also was we reconfigured, for example, for diabetes in particular, into what we call a solution shop model, and started something that was called, with the guidance of the ministry, the Diabetic Wellness Center. This provided the patient the opportunity to receive multiple engagements or multiple components of diagnostic care or diabetic care at the same time and at the same place, as opposed to along a continuum of care. So normally what would have happened way in the past is that a patient would come into the diabetic clinic, see a doctor, the doctor would then prescribe tests, the patient would have those tests done over time. Sometimes the patient may deteriorate and further tests would be done later on. What we've done, and perhaps the patient would have required ophthalmology because diabetes started to affect their eyes. What we've done now is when the patient arrived, we engage and this is a diabetic, quote-unquote, patient referral. The patient arrives to the Diabetes Wellness Center. We engage in the tests that are required. The test results arrive in the second, after lunch, but during the day, the patient would see an ophthalmologist, the patient would see the podiatrist, the patient would have diabetic education, dietetic education, and so that by the time the doctor arrives or the specialist arrives, we have the results for the test. So that when that patient makes the arc to seeing the doctor, they have the test results there, and we basically so the specialist is armed to provide the best possible prognosis and projection for care. And as well, based on that, we bring the medication to the patient at the clinic. So we've not only optimized the ability to do the test faster, but given that we found that we can do it faster, we've reorganized for diabetics the way that we operate. So instead of a patient receiving those services along a long 3-4 week continuum of care, they receive that at the Diabetes Wellness Center at the same time, on the same day.
Thank you. Thank you, Chair. Highlighted in your submission as a 2022, the cancer detection rate in Trinidad and Tobago was 209.4 per 100,000. Does the Ministry of Health have a medium-term target for reduction of this relatively high cancer rate within our population? Example, a reduction within the next 10 years, maybe of 5% or so?
First of all, to add to that, if I could, would that be considered a high rate? 209.4 per 100,000, would that be considered a high rate?
Sorry, Chair. Member again, could you just, the page please, if you don't mind? Thanks.
It would be page 15, question 6. Or maybe not. This is just some cancer detection rate information, sorry. It may not be that question.
It's just some cancer detection rate information.
Yeah, information. Yeah. It may not be cited as a question or submission. So the first question is, would 209, generally 210 persons per 100,000 be considered a high cancer detection rate for a country? And if so, is there a plan to reduce it? Page 14, point number 3.
Okay, thank you, Chair. So, Dr. Allen, Mike. So, I don't have the international data to compare it to, but in terms of your question with regards to what the ministry is doing, so I can speak from the point of view of being involved in therapeutics. So, one of the things that we are aware of is that the incidence of cancer tends to be greater in families where there's a genetic link. So particularly at the center, we have direct access to patients that we are actively treating. We use that opportunity also to engage the patients and their family members in terms of the different options for screening, so that we have a great opportunity to capture a large percentage of patients that would fall into that niche that would be most likely to be at risk for developing cancer. And it's also an opportunity for them also to relate to friends and family as well. So looking at trying to enhance with what Dr. Clapton would have mentioned previously in terms of the uptake for screening, the different RHAs and programs and wellness fairs that they have, we add on to that with that aspect of targeting that group of people that are most at risk.
Just to add to that, one of the data points is that according to WHO 2020 country cancer profile for Trinidad and Tobago, using 2018 data, there were 3,369 total cancer cases and 1,988 out of an estimated population of 1.3. And the same document showed in 2016, there were 4,027 premature deaths from NCDs, of which that made up cancer with 22.9%. So it kind of feeds into the question about how effective are cancer detection methodologies and our cancer treatment protocols. I don't know who wants to take that. And if we're seeing decreasing or increasing trends in the primary cancers, which is breast cancer for women and prostate cancer for men, if that's correct.
Sure. Yeah, sure. I could address some of the issues with women's side. So yes, breast cancer is the #1 cancer in our women in Trinidad and Tobago. So again, the data comes from the Elizabeth Coroner's National Cancer Registry, and they have data up to the year 2020 and how the registry works. So in terms of cancer reduction, of course, we of course would look at targeting cancers that are preventable with screening and so on. There are some cancers that don't have a screening program. So breast cancer is one of those where we will try to detect cancer early. You already have cancer. Cervical cancer is another one of those, but you're trying to prevent cancer from occurring. So there's slightly different terminologies. Trinidad and Tobago, we actually, for the first time, had formal policies put in place in terms of our screening programs for breast cancer. On average, every day, in terms of numbers, 1 case of breast cancer is diagnosed daily in our country in Trinidad and Tobago.
1 every day.
1 every day, and put it into numbers. It's a little more than that, it's 1.3, but at least 1 case per day.
Which means if 1 is being diagnosed every day, we can presume there are more than 1.
Yes,
Okay.
This is in terms of our detection, and of these patients, it's a different cohort, of course. 2 women die every 3 days from breast cancer, according to those statistics. 84% of breast cancer cases occur after the age of 45 years, which is similar worldwide. And 90% of deaths occur in women who are 45 years and over. So Trinidad and Tobago, we actually do have a screening program, a policy, which we did launch earlier this year at International Women's Week.
I'm kind of shocked at that. Is that benchmark, if I could use that term, for the region and/or the world, in terms of 2 women dying every 3 days?
I will have to, of course, look at those numbers in
please,
terms
thank you.
of it. But
It just seems significant and profound
It is
to me.
significant. That's why, of course, we have so many NGOs and other departments trying to bring this to the fore at all times throughout the year. But for the Ministry of Health, we did have one big event earlier this year when we did try to highlight it. Every year now we have that on our portfolio, International Women's Day in March, where we highlight this and we increase the numbers of persons being screened. So our current screening program for women at average risk, these are not high-risk women, between the ages of 45 to 70 years old. I take this opportunity to ask you every 2 to 3 years to visit your regional health authority where the mammography is the mainstay for screening. And that's the program we have in place. For women who are at higher risk, you speak with your clinician, and that is if you've had a first-degree relative who's had breast cancer, we start the screening much earlier and much more frequently. For cervical cancer numbers are actually slightly decreasing for a number of reasons, one of which is the HPV vaccination program, which started in the year 2013. The more HPV vaccines a country delivers, you will reduce the incidence of pre-cancer and cervical cancer. Cervical cancer is the number 4 cancer in women in Trinidad and Tobago at this time. The numbers are approximately 113 cases per year, of which 17% present early, which it works out to about 1 case every 3 days being diagnosed. So all these are very high numbers, of course. So Trinidad and Tobago, we have signed on to try to eliminate cervical cancer by the year 2030 with a number of strategies, including new tests for screening and so on.
Thank you. Member Nakit, go ahead, please. Thank you.
I think they can hear me. But they are available at specific cancer treatment units. Are there any challenges about the availability of cancer drugs at these units?
Thank you, through you, Chair. No, member, there are no challenges with the cancer drugs at the respective units, and the cancer drugs are not part of CDAP, but as I said, they are available at the respective RHA facilities.
Your submission stated that interventions have been put in place to support the reduction of tobacco usage. The main challenge that you encounter is due to behavior change. What do you think can better assist with change in perception about tobacco usage?
Thank you. I think public education is key. It's critical so that persons, those who are, as CMO alluded to, who have not yet started smoking are aware of the dangers of smoking and do not start. And for those who currently smoke, to provide that support, it is a smoking cessation clinics to assist them with stopping smoking. We actually do have smoking cessation clinics.
Let me interject. Give us an example of how much is your budget for a public awareness program. What is your budget?
That's a difficult question. So we have a budget for communication, for health promotion, which would cover not just NCDs, but other things. I mean,
well, tobacco specifically, do you have any idea how much you put into advertising campaigns, public awareness programs, so that we can make the public more aware of the dangers of tobacco smoke?
I'll have to get that figure for you, member. Right. But if I may just complete what I was saying.
Yes, go ahead, please.
Yeah, in terms of those persons who are currently smokers, we do have smoking cessation clinics at the RHAs. We have some of those, and we want to actually ramp those up and increase those, so that persons who are actually already smokers, we can assist them in terms of stop smoking.
To follow Member Nakid's question and a conversation we had earlier on, it would be helpful for us if you could liaise with your Ministry of Trade to get a sense of the importation trends in tobacco products, because that's, to me, the only way past doing a national survey and asking people, do you smoke? How much do you smoke? You'd find out if there is a success story in the intervention strategies for anti-smoking campaigns. Because in the absence of that, we won't know, and we won't know the success if the money is being wasted, if there needs to be a different approach to the campaign, if you need to target a different age group, because the tobacco importers won't continue importing products that are not lucrative for them. And in a related matter, I don't know, because to be fair, it wasn't part of our initial submission to you, but is there emphasis being placed on vaping because of the documented impact, negative impact of vaping in terms of respiratory diseases?
Thank you. So yes, Chair, to answer your question, we are looking at vaping currently. Our tobacco control unit is actually actively looking at the matter of vaping, and we hope to have a policy developed soon as it pertains to vaping.
Thank you. Member Nakid, you finished?
I have one
Go
more
ahead,
question.
please. Thank you.
This question is a bit off of the paper, but from my constituents. I grew up in Shafler, so this is anecdotal. And from my research, Whitco started there when it was a very rural community. There weren't many houses and communities around that area. Now there are. And the emissions coming out of Whitco, I mean, the level of cancer that has been noted in and around that area, Mount Lambert, St. Joseph, and this is important for the national community. Are there any plans in the Ministry of Health, maybe, to relocate a factory like Whitco from what is now a very residential area?
Just if I could intervene, the ministry can't relocate a factory.
No, but just...
But they could make recommendations.
They
I guess, an additional question to that is, are any studies being done in and around those areas to identify the potential impact of the air pollution issues that may or may not be there, and their impact on the general health of the population around those areas? That I think you can answer.
So in terms of air pollution and that sort of thing, it is not the remit of the Ministry of Health to measure air quality. That is outside of our remit. That is under our Ministry of Planning, if I believe, in terms of measuring the air quality. If you're suggesting that there's a putative disease cluster around Whitco, then we can certainly examine and see if there's evidence that suggests that. And if there is, then make recommendations following the identification.
That is exactly the question that has been posed by the constituents.
Okay.
So you will look at that?
If you have raised it as an issue by a member of the public, we can certainly investigate and see if there's any evidence to support that claim.
Okay, thank you.
While you're at it, I may just add this. My personal concerns about the groundwater from that area by the BSM there, in that very filthy chemical-filled drain, may be something you want to check out also on the impact of the pollutants from the landfill that may or may not be affecting the residents of the BSM for decades in this country. Maybe something you want to investigate. Can we go to Member Monroe, please?
Thank you very much, Chair. My next question is based on public awareness initiatives. Your submission stated some strategies used in marketing against the consumption of unhealthy foods, specifically the commencement of the upgraded Health and Wellness Festival model through TT Moves. Question 1960. Can you?
I think we have covered this already. Yeah, we may have covered this already.
Yeah.
Right. Thank you so much. Let's just, because we're running out of time, I just wanted us to focus a bit on diabetes itself and the information that we have. And in a quotation from a 2018 newspaper article, there are more than 175,000 people currently living with diabetes in Trinidad and Tobago, and millions of dollars being spent by the government to treat patients. The report also states many persons are pre-diabetic, and there's a high prevalence of diabetes is genetic. It is estimated the government spends around 10,000 persons per month, dollars per month on dialysis. Can you give us a sense of what the ministry's initiatives are in dealing with diabetes? I know, I think it's Dr. Let me put on the glasses, Clapperton would have indicated that knowing your numbers is critical, and how much emphasis is being placed on awareness related to diabetes, pre-diabetic, the types of diabetes, whether it be gestational or not, and how we're dealing with diabetes in Trinidad and Tobago as an NCD.
Thank you for the question, Chair. So again, I would just like to reiterate the ministry's life course approach to addressing the issue of non-communicable diseases, and in particular diabetes. And just to add to the contributions made by my colleague, Dr. Surjit Singh, as it pertains to the diabetes in pregnancy programs, preconception initiatives, and other initiatives for diabetes in pregnancy, and also breastfeeding initiatives, as this is also key in terms of preventative measure for diabetes later on in life. In terms of the focused and targeted measures that we do have implemented at the Ministry of Health, and it was mentioned previously that we have implemented a series of diabetes wellness clinics, which are focused clinics that enlist and take a multidisciplinary approach towards addressing and controlling persons who have been deemed to be where their diabetes is out of control. And this is just to supplement something that we already do within our system. We do have the series of local health centers in our primary healthcare system that have chronic disease clinics that cater to persons with diabetes and hypertension.
How successful has the ministry been in addressing the cultural mindset? Well, we have a little sugar in our family. That is no big deal. It ain't kill my grandmother or my mother, it ain't kill me. And getting people to take that seriously because of its impact on your health. Because that is part of the cultural landscape.
So we do identify with that comment as well, and we are trying our best under the umbrella of TT Moves, which is not only a behavior change campaign, and also with the TT Moves Wellness Festivals to educate members of the public, not only providing services of health screening at these events, but also to share information with persons about what the nature of diabetes and what can be done to prevent, manage, and control. Our diabetes wellness clinics have a series of services provided for persons who have been deemed or attended their chronic disease clinics at their health centers and found to have uncontrolled or HbA1cs above 8. Right, and these persons are referred into these specialized clinics where they can receive focused care to manage their diabetes. And these clinics can provide services where we have endocrinologists, and we also provide eye care and foot screening and dietitian and nutrition counseling at these clinics. So the concept is a one-stop shop for persons who have uncontrolled diabetes, so they can have this focused care to help and better manage their blood sugar numbers. And we do have, in the first instance, some information coming out of these clinics in terms of the levels of control, because we do have in these clinics strict admission and discharge criteria by way of the HbA1c numbers. So we do have, for example, in one of the clinics, we would have had a patient, for example, patient 1 was admitted with an HbA1c of 12%, and this patient, after receiving care at these clinics, would have been discharged with an HbA1c of 6.1%, and this would have been a patient from NCRHA clinic in 2020.
Are there any plans for the ministry to start following global models of mandating caloric content of packaging and foods? And I think in the case of the UK a couple of years ago, limiting sugar intake in some instances legislatively, plans to change the laws where that is concerned. It was considered drastic in the UK, but it worked.
Thank you, Chair. So that is a conversation that's happening right now between the Ministry of Health, the Ministry of Trade, and our various stakeholders. So there is a committee called the Food Advisory Committee that sits within the Ministry of Health that includes all those players, and that is a conversation that's taking place as we speak.
Final questions. Member Mohit, we'll start with you, please. Thank you.
Thank you, Mr. Chair. I note in terms of the NCD economic burden, in 2018, the average cost per person in terms of dialysis per month would have been 10,000. Do you have a figure as it relates to 2023?
So the average cost per person would not have changed, member, through the chair. So that is the approximate figure to dialyze a person for 1 month. What I can give you would be the number of persons
currently on.
That's how many sessions? Depends on the patient.
It depends on the patient. It's normally 2 sessions a week.
Yeah.
3? Yeah, 3. But again, 2 to 3. But it depends on the person. Let me just get the figure for you with the number of people on dialysis right now. 1 second.
And the number that you're providing would be both at the for both at the RHEs as well as private, public.
So what I have here would be the private, 729 persons access care at the private centers. The RHEs would have the figures for the public system.
Just to go a little further, how many persons are awaiting approval for dialysis?
At the ministry right now, 5.
5?
Yeah.
5 persons?
At the ministry. Yeah.
Just one additional question. In terms of the NCDs, I know chronic kidney disease is not one of those we are examining, but obviously it's stated here because it relates to diabetes in some form or the other. What is the ministry doing at this point, or at this stage, or what stage are you all at in terms of dealing with chronic kidney disease as it relates to the various RHAs?
So, in terms of chronic kidney disease, that is addressed at the secondary care level. But before we even reach there, at the RHA level, we are looking at a preventative model so that people do not get to that point. But at secondary care, those who come in and require dialysis, we address that and we dialyze, and we also treat on a case-by-case basis for chronic kidney disease. But just to reiterate, there's a heavy focus on prevention in order to address the reduction in us having to deal with chronic kidney diseases.
You mentioned RHAs would have the figures in terms of those who are on dialysis. If they can't provide it now, in the interest of time, can you provide it in writing for us?
Yeah.
Sure.
At Eastern RHA, we currently have 80.
Sorry, Chair, if I may, sorry. On page 14 of our submission, number 4.
I didn't see it.
So that's fine. We would have given the numbers for the respective RHAs into the dialysis.
Yes, it's there. Thank you. We have it documented. It's on page 14. Member Monroe, go ahead, please.
Thank you, Chair. Question directed to Acting CEO for the Eastern Regional Health Authority. Given the success of the last community health outreach program in the northeastern communities held by the ERHA, the residents would like to know, this is a question posed to me through the residents, can they look forward to regular health outreach programs in the many rural communities, given the vast geographical distance, maybe on a monthly basis, where the Eastern Regional Health Authority would come into the communities instead of waiting for them to take the journey to come to the health facilities at worst case scenarios?
All right, so yes, we do cover 1/3 slice of the island. However, we have outreach activities from Matlot, as far as Matlot in the north and Guayari in the south. Recently, we had a diabetes walk November, a diabetes walk which we engaged the community on the north coast. So we do go out to the respective communities and conduct outreach programs. There are several initiatives on a monthly basis, maybe not on the grand scale as the wellness festival that we had recently, but it's focused outreach programs. Our focus this month is diabetes, so you would see a lot of that. We would have had outreach for Fruit Fridays and Water Wednesdays. So yes, the Eastern RHA continues to go out into the rural communities and provide health and outreach programs, small scale as well as the grand scale, as we recently had at the Wellness Festival. So yes, the residents can look forward to that.
Okay, thank you very much.
The last risk factor survey was in 2011. And it noted from your submission that we had a 26.7 rate of childhood obesity. I think that is a lot higher now. Give us some updates.
As I said before, that was the 2011 survey. Normally happens every 10 to 12 years. It's a large health survey. That is a ParlView-driven tool that we use. So the next update, the next completed version of that will happen next year, hopefully, all things being equal. And once we get that data, we'll be able to tell you how it compares to the 2011 data, if it has improved, if it has gotten worse, and that will give us an objective point of view without anecdote, without trying to make any comments from an anecdotal standpoint.
So we'll have to wait until that survey is done to have any idea about. Because childhood obesity seems quite a problem, especially since COVID, 2 years, a lot of kids were locked down.
I mean, it's to make a statement without the proper evidence would be, I'll be a little bit amiss to say something that I don't have the data to back up. So I want to wait on this study before I can make a proclamation on the level of obesity that currently exists. Beyond 2011, though, we did present the 2015 data, which suggests a high level of obesity as well. Not as high as probably 26.7, but it was high as well in 2015 when the global youth survey was done in a select group of people.
Thank you. My question will come from some questions that I've been getting from the media, which goes back to an earlier point Dr. Amor raised and divulged some information. If you could just give us a chronology of what actually happened with the data breach at your institution, because I've gotten 4 requests for more information on that while I'm sitting here since you divulged that information. What actually happened on the day? When did you realize the breach occurred? And what steps were taken in the time following that?
Okay, so at 3:45 a.m., due to our routine monitoring, we realized that some of our data was inaccessible. The term that they used, that they were encrypted. And therefore that prompted the due diligence protocol to simply shut down the network, call law enforcement, and certainly to prevent any propagation within the network, to shut down the entire network. So that was prompt actions taken at that time. So some of the storage data that was online have been locked, but what we have been able to do is to recover a large measure of our data based on our local redundant backups that we do have. Some are locally at departments, some are older versions of data. So that is essentially what happened from the end user perspective. Administrative systems were impacted, the computers were off, if you would appreciate, like human resource, finance departments and so forth. But we were able to, for example, preserve payment to staff salaries, which was our electronic software that was maintained. So staff received their pay, and that was preserved. Also, 2 core patient systems were preserved. We did have the ability to still process lab results, still process radiology results, and still able to record and interview patients and treat with their illnesses, which is our core business. So those systems were maintained. and therefore in the recovery mode we have been able to reconstitute a large part of our data. Part of it involving law enforcement was to clean our network for the malicious software. That effectively involved having to literally go to each and every computer, as I said, from Icacos to Tabakit, Freeport to Maruga, and physically scan the computers as well, so that ADIOS task was done. And for that, want to state on public record, do thank the support of the other RHAs to assist us there, as well as other agencies and providers. So we have crossed that hurdle, and we are back to full recovery. Patient care was not impacted. Critical employee services were not impacted. And therefore, we are on the way forward, and we are taking guidance from the Ministry of Health and Law Enforcement in terms of the way forward. And even during that time, we have done all the remedial measures to the interim satisfaction of TTCert that has enabled us to reach where we are, to connect back to networks, to connect back to our software, to resume the digital business of the authority.
Was it determined to be a deliberate act? And has any agent or person been identified as the perpetrator?
I would have to say that investigation is ongoing. It's in the hands of law enforcement, so that will be TTCert. That would be best poised to provide the answer to that question. But in terms of it has been deemed malicious, in terms of it is malware, and therefore the way forward is just simply a matter of prevention. As we speak about prevention in that regard, we just have to prevent the attacks and just have that level of security that is required moving forward, and keeping up to date with the current cyber world environment that's out there.
Thank you. In closing, would the PS or CMO care to deliver closing comments?
Thank you, Chair. Just on behalf of the team that is here, thank you very much for allowing us to share some of the work we've been doing at the Ministry and the RHAs in terms of the whole of government, whole of society approach, and to share with the public the issue of NCDs. And as I said when I started, while the Ministry of Health and the RHAs and the rest of the state machinery has a role to play in providing that enabling environment, there's definitely a place for civil society. We've seen that support and collaboration with them, and obviously at the level of the individual, to make those informed lifestyle choices to also look after their own health. And thank you again to the committee for some of the suggestions that were made. We'll definitely take those on board as we go forward.
Thank you so much. We'd like to thank you, the Permanent Secretary, Mr. Ali, Dr. Pasram, Dr. Clapperton, Mr. Blake, Mr. Rampasad, Mr. Thomas, Dr. Armour, Dr. Ali and Mike, Dr. Surja Singh, and Dr. Cummings. Thank you all for being with us and sharing the information with the committee. And we appreciate your time and your contribution, and those of you who delivered comments and questions to our platforms. The public is advised that the committee's sixth report on an examination of the state of technical and vocational programs and their contribution to achieving the development goals of Trinidad and Tobago was presented in the Senate on the 20th of October 2023 and in the House of Representatives on the 1st of November 2023. The report can also be viewed and or downloaded on the Parliament's website, www.ttparliament.org. We thank you and all stakeholders and committee members and the staff of the Parliament for their procedural and logistical support, and to the viewing and listening audience. Thank you all. Our meeting is now adjourned.